Excellent, thank you. And just for a note, the recording is going to be included on our cost board webpage shortly after the meeting. TBW may also be streaming this live and archiving it for additional viewing in the future. So we have a pretty packed agenda today, which can be found in the first tab of your meeting packet. And at this time, I'm going to hand it off to our esteemed interim chair, Michelle Needham, who will now call the meeting to order.
Thank you, Russ. Calling the meeting to order. Our little gavel. Welcome all board members. Thank you for joining us today. I know it's a busy time of year, especially with legislative session and a lot of other activities. We appreciate your time engaging with us today. If you can turn on your cameras, that would be lovely. Those of you who are, you can also see your faces participate with us today. I just wanted to point out, as we have the agenda up on screen, we have a range of topics today. Just going to mention them in passing. Obviously, the approval of the January meeting minutes, public comment as usual, and then a presentation from a team of people. Actually, our names have changed since this was published, with Amanda in our data shop, Amy Kinner from OnPoint, and Ross Valori, our director of the cost board. We'll do a discussion on the cost driver analysis under tab 6. So they'll be presenting that, which picks up from last month's meeting where we reviewed the benchmark aggregate data. And this is a deeper dive with some of our claims data out of our APCD, our all-payer claims database. And then we will follow that with a related conversation from our analytics support initiative, which is our project funded by the Gates-Peterson grant at the University of Washington. We'll finalize their analysis priorities for the rest of that grant. Again, as Ross noted, that will have a vote to finalize that agenda. Then we'll have a continuing discussion with staff and others around the assignment the board had given earlier in November and December around the NASHB Model Act, business oversight data gaps. That's the plan for the day. With that, I think I'll turn it back to Ross to do roll call board members.
Thank you, Michelle. And today we'll do just a little different roll call style for attendance. So I will just call out names. If you could just say yay if you're here, we will note that. I'll start with Jane Byer.
Oops, I am here.
Great.
Thanks.
Yes, thank you, Jane. Eileen Cody. Okay, we can come back for Eileen. Louise Cook.
Lois, yes.
Lois,
I'm
sorry,
here.
apologies.
Sorry.
Here, though, thank you. Bianca Frogner.
Here. Hi.
Ken Gardner.
Here.
Jody Joyce.
I'm here, thanks.
Greg Marchand.
Here.
Mark Siegel. Okay, we'll come back for Mark. Margaret Stanley, who I believe will be absent today.
No, I'm here.
Sorry. Thank you, Margaret. Ingrid Ulrey. Okay, we'll come back. Kim Wallace.
Here.
Carol Wilms.
Here.
Here. And that is it. I'll call again Eileen Cody.
Eileen let me know she wasn't going to be attending today.
Okay. And Mark Siegel. Excellent. Well, that is roll call today. Thank you all.
Before we start the meeting minutes, could we take one moment to allow Ken Gardner to introduce himself? It is his first meeting that he's been able to join us. I know we introduced him at last meeting, but he was not able to join us. So Ken, if you'd like to take a moment to introduce yourself.
Sure. Hi, everybody. I am Ken Gardner. I'm with the SEIU 775 Benefits Group. And prior to that, I spent about 15 years at CMS working primarily on Medicare Advantage and health insurance marketplace programs, as well as COVID response. Also was at University of California, San Francisco as their administrator for Department of Medicine, and later administrator of their medical group when they launched that program. And I'm just delighted to join the group. And I'll also say I worked with Ingrid for some time while she was with the feds as well. Thank you.
I'm so glad you're here, Ken. Thank you.
Excellent, thank you. I'm going to now turn it back to Michelle for approval of the January meeting minutes.
We can turn to tab 2. I think those meeting minutes are up on the screen and you had them in your packet. Is there any discussion of the January meeting minutes? Seeing none, is there a motion to approve the minutes?
So move.
Seconded.
Second.
Perfect, thank you. Calling for a vote, all in favor say aye. Aye.
Aye.
Aye.
Anyone opposed? Say nay. Approved. Go. Right, should we move to tab 3? And we will have Ross lead us through public comment.
Thank you, Michelle. We are to our public comment portion of the meeting. So we'll discuss or go over any comments received since our last meeting. This can be found in the 3rd tab of your meeting packet. We're happy to let folks sign up to provide public comment before the meeting, and we'll start with those that have signed up to provide comments. If you've not signed up and you'd like to provide public comment, please raise your hand, and then I'll call on you once the individuals who have signed up have gone. When you're called upon, please state your name and affiliation, if any, before speaking, and we will let you go. Please accept the invitation to become a panelist in order to turn on your camera, similar to what we had talked about with board members. Accepting that panelist link will allow you to turn on your camera and your microphone. And we don't, I believe, have very many comments today, so we can probably give 3 minutes per public comments, and if there's additional time, happy to yield that back to the public commenters. You're also welcome to provide public comments via email at any time, and we welcome those. So please feel free to submit those. Turning to today's public comment, I know that we received some public comments from hca, which is provided in your 3rd tab, but not seen anyone here from hca and wondering if there's okay. Excellent. Okay, it sounds like we have Katerina here, and I apologize. I'm not able to see the screen.
Ross, we can also note that Ingrid has joined us virtually, so she can be noted as present.
Hi, sorry, this is Katerina LaMarche. I'm a policy director at hca, and I don't have my camera on. I'm sorry, I'm having a lot of Zoom troubles today. But I wanted to first say that we really appreciate staff's work to release the meeting materials in advance, and we also appreciate staff's recognition that there might be a cost shift occurring from inpatient to outpatient, which contributes to the cost increase for hospital outpatient services. And this comment's directly related to the cost driver analysis that you'll be discussing later during your meeting. We submitted our comment prior to seeing the updated cost driver analysis, so we wanted to add a few points today and reiterate others that might be helpful as you review the presentations. And the presentations are really helpful. We just think it's also important to examine the data at a more granular level, if possible, by looking at types of cases treated and case mix changes in inpatient and outpatient services. For example, though procedures are being performed more frequently in an outpatient setting, the acuity of patients requiring inpatient procedures is actually also increasing. So we can see some of these examples in bladder and hip and knee-related procedures, so it might be good to do a further examination of that. One thing we'd like to note, we request that the graphs and tables that just say price be changed to price and intensity to reflect that we don't know which is responsible for increases. And it might also be helpful to look into other data like the numbers of people enrolled in each of the payer categories used for this analysis in case there are some yearly enrollment shifts, and we plan to follow up with a more specific data request. And we also want to note that while identifying cost drivers is important, we think it's equally important to consider how cost reductions should be accomplished. You know, that hospitals are struggling to reach positive margins, and in addition to their financial issues, there is proposed legislation that would cut approximately $647 million in state funding for hospitals if fully implemented. So we're just left with a lot of questions about what should hospitals do to maintain their services? We're really constrained by cost inputs that are increasingly being driven by inflation that isn't necessarily accounted for in the benchmark methodology. So wanted to point out one other thing that our written comment highlights, which is one of the major hospital expenses is nursing salaries. So should hospitals reduce staff or pay? And if not, how should hospitals operate with less revenue? The other option is cutting services. So we do agree that it's important to try and make care more affordable. So we would just encourage the board to work with us in figuring out solutions that won't jeopardize access to services or quality of care. Thank you.
Thank you so much, Katerina. Really appreciate that. And just want to take a moment here. I'm not seeing any other hands currently for public comment, but just going to pause for just a minute in case anyone is interested in submitting public comment. Don't worry, I won't make folks wait a full minute in silence. Not seeing any hands come up. I think that we are good to move on now. So let me just get back to my script here. All right, excellent. And I will pass it back to Michelle to transition us to legislative updates. And again, just wanted to thank Katerina and Wisha for their comments and encourage anyone else who'd like to submit any comments. We accept them anytime if you submit written comments. So would love to hear from you. Thank you.
Great, thank you, Ross. Turning to tab 4, we will share a legislative update. We have our Special Assistant for Policy and Legislative Affairs, Evan Klein, give us an update on some bills that are related to topics that the Cost Board is interested in. Evan.
Hey, just checking, making sure folks can hear me online.
Sounds great.
Awesome. Good afternoon, and thanks for having me here again. I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs at the Healthcare Authority and generally manage our state legislative relations. So I am here to provide a kind of very brief update specific to a couple of bills that may be of interest to the Cost Board. Just highlighting for folks that have been tracking as closely, at this point, legislative session, the legislature has moved past the first policy and fiscal committee cutoffs and is now working through floor action today and the rest of this week to move bills out of their chambers of origin. So some of the bills I'll talk about today, we would consider likely dead this session, probably not moving considering they're still sitting in a committee, but did want to just give you a little bit of brief background and then happy to take questions. If you could jump back maybe 2 slides. So just to start, in this space, 2 bills that HCA is running as agency request legislation this year. I think we've talked about both of these with you previously, but just to give you kind of a status update, first is Senate Bill 5083. It also has a companion in the House, House Bill 1123. It's around ensuring access to primary care, behavioral health, and affordable hospital services. It's looking at instituting a reference price payment structure in the PEB and SEB program. So looking at controlling reimbursement for hospital services, both inpatient and outpatient services, and then setting some floors for payment for primary care and behavioral health services. So some redistribution of spending within the PEB and SEB program. It is tied to some cost containment modeling that we know has been something that's been kind of discussed quite a bit with the legislature given the state's budget conditions, but is a proposal that we put forward this year to think about reducing the state expenditures, but also out-of-pocket expenses for state and school employees while simultaneously investing more into primary care and behavioral health. Right now, that both the Senate and House bills are out of their fiscal committees. We are anticipating that it's the Senate vehicle that would move if either were to continue to advance this session and likely up for some floor action this week. The other of our agency request bills is House Bill 1382 around modernizing the all-payer claims database. The bill really focuses on two things. One is kind of more of an administrative step to ensure that the state could continue to operate as a lead organization for the APCD in the event that we don't have a vendor that's secured through bid to run that function. But it also changes some of the policy within APCD around what data can be shared out and utilized by the public and by policymakers, by the cost board and others through data analysis. So there's a definition in statute today around proprietary financial information that restricts certain data from being shared, largely paid amounts and negotiated rates. That is information that has since the APCD was enacted, it's been required to be published at the federal level. So there's some federal rules that were enacted in 2020 called the Transparency and Coverage Rules that require hospitals, health insurance carriers, and providers to publish their rates information online through machine readable files, kind of putting that information out into the public sphere, this bill is trying to true up our state's all-payer claims database with those policies. This bill likewise is sitting on the House floor with the potential for floor action as early as today. So continuing to move and expect to or hoping to see that go over to the Senate within the next week. Next slide. So next, I'm going to get into 5 other bills that we just thought might be of interest for the committee. The Healthcare Authority has varying levels of engagement here. I know the Office of the Insurance Commissioner, the Health Benefit Exchange have both been engaged in some of these as well, and may be able to provide some additional background. But wanted to share a couple of these with you as they're all either moving through session or at least had some discussion early in the state legislative session. So the first is Senate Bill 5387. This is concerning the corporate practice of medicine. There are some statutes already in place in Washington around limitations of when an individual with an ownership stake or can have an ownership stake in healthcare when it's kind of a clinical practice, and some prohibitions on non-clinicians getting involved in clinical decision making. This is an expansion of those existing policies. It would prohibit the corporate practice of healthcare except through professional service corporations or limited liability companies, and prohibit individuals that aren't licensed to practice healthcare from interfering with the clinical decision making of healthcare providers. We know that there's been kind of growing scrutiny around private equity getting involved in healthcare entities, and some of kind of the business side bleeding into the healthcare delivery side of clinics and other outpatient related services and hospitals. So I think this bill is kind of largely trying to take on, what's the state's role in ensuring that there's that bifurcation, particularly around clinical decision making. Healthcare Authority hasn't been closely involved in this bill, but it has continued to move so far, and is, I think, sitting in the Senate Rules Committee. So again, we'll be waiting to see if there's any Senate floor action on that this year. The second bill here is Senate Bill 5493 concerning hospital price transparency. This is a bill that was run by Representative Vercelli. It is also in the Senate Rules Committee. It has been amended through the process. The bill originally started out taking a page from those federal transparency and coverage rules that I had previously referenced that require hospitals to publish machine readable files with their negotiated rates, and was requiring some similar kind of proxy policies at the state level with some state level enforcement as well. The bill has been kind of amended through the process, currently requires compliance with those federal rules. So instead of creating a state level reporting requirement that's a bit kind of commensurate, it simply requires compliance with federal rules, and then provides some requirements to submit data to the State Department of Health. So still moving, a bit changed from its original function, but I think targeting ensuring that our state's hospitals are in compliance with those federal transparency rules. And again, the data there is kind of focused on negotiated rates. I don't know if it's been discussed before the cost board, but a good example here, Colorado has taken some of that information that's being published through those federal rules and actually put it on a dashboard that they have, a public-facing dashboard, where folks can look at by hospital and by payer what rates are being paid for certain service lines. The last bill on this slide, 1589, is concerning the relationships between health carriers and contracting providers. This is a bill being run by Representative Bernowski. It's really targeting the Office of the Insurance Commissioner's role in kind of oversight of health carrier networks and ensuring that providers are actually able to provide services to enrollees. We know that a kind of common refrain when talking about network adequacy standards is that there may be a provider that's in network, but how does that translate to actual access when an individual needs to receive care? So looking at some additional oversight in that space, also creating some policies around negotiating in good faith. So some requirements around how health carriers and providers negotiate and prohibit certain contract terms in that space as well. So largely focused on Office of the Insurance Commissioner's oversight in that space, and thinking about how to study those impacts over time. Next slide. So two more that wanted to cover. This other one around a healthcare entity registry. There were both House and Senate bills. So I should reference there's Senate Bill 5561, which is a companion to House Bill 1686. But the House bill has been kind of the vehicle that's moving here. This is kind of started focused on a kind of broad kind of healthcare registry and thinking about you know, submission of certain ownership data, certain data by provider and provider type, ownership, affiliation, and services that are being provided to the Department of Health on an annual basis, and then actual creation of an interactive tool for the public to be able to track where providers are around the state, what services they provide, what their ownership affiliation might be. The bill has been amended through the process to largely focus on the data submission as opposed to the public-facing portal aspect of the underlying bill, but with the goal being somewhat the same, focusing on ownerships, affiliations, what services are being provided, getting that data to the Department of Health, and then making that data publicly available. That bill still moving ahead through the process. I know there's some focus here on kind of cost and actual implementation. And I know that Department of Health may have some additional expertise or background on this policy. Again, something that the Healthcare Authority hasn't been as closely involved in, but we are tracking because we know that knowing where providers are around the state does help in our analyses. And I think it's come up in conversations when we're trying to look at network adequacy standards, when we're looking at cost modeling, and trying to look at like distribution of services around the state. There's a bunch of different analyses that we've done in the past where, having some of this information could be very helpful for the state. And then the last bill on here is House Bill 1881. I think at this point can safely say that it's unlikely that this policy will continue this legislative session, but this is something that the legislature has taken up for deliberation the past couple of years. It's around transaction review and mergers and acquisitions. I know that the cost board has spent a lot of time talking about the NASH-P Model Act around mergers and acquisitions. This bill takes a policy that the legislature had been debating the past couple of years, largely focused on a state attorney general oversight structure of mergers and acquisitions in the healthcare space and built on it to pull some of the components, some of the ideas that are in that NASHP Model Act into rethinking what merger and acquisition oversight might look like. So this is it's been an iterative conversation in front of the legislature the past couple of years, but this House bill looked at bringing the healthcare authority into the fold. And so it requires that when there's a transaction, there's notice provided to the attorney general and the healthcare authority, that the healthcare authority then be involved in actual transaction review. So looking at the complexity of that transaction, what the impacts might be to service delivery, to access, to affordability as well. And then there's some preliminary reviews, and then it can go to a more complex, comprehensive review if necessary, and if the transaction is large enough. And then thinking about kind of enforcement. So if there's some requirements in the bill for the attorney general to contemplate approving the transaction, denying it, or approving it with conditions. This is we've pulled pieces, or this bill kind of pulled pieces from different statutes around the country. We know Oregon has a transaction review process. There's some states on the East Coast that also have various transaction review processes that all pull in their state's healthcare agencies into that, and not just leveraging their state attorney generals. And so I think that was the impetus here. So obviously the healthcare authority kind of involved in some of the brainstorming that had taken place earlier this session around this bill, and some of the deliberations. The bill didn't pass policy committee cutoff. I think, members would still consider a work in progress. We would anticipate this is probably a policy that will keep coming back before the legislature. And our role as an agency really just kind of applying some of our expertise and engagement with sister states, and trying to be helpful with legislators in answering questions and being available to help with implementation if it got to that. So with that, those are kind of the bills that I wanted to highlight. Happy to take questions, or I know, there's others in the room who probably have some additional background on these policies, but do appreciate you letting me come before you, and also, happy to be a resource. I know the cost board team certainly has my contact information, but happy to hand that out to others if there's anything that could be helpful offline.
Thank you, Evan. I'm looking to see if there's any questions, or if board members want to comment on the legislation that you overviewed, or add some additional bills to the boards. Jane, Kim, other state agencies that are actively engaged in legislative activity. All out.
I think the only,
go ahead, Jane.
yeah, I think the only other bill, one of the other bills that I would mention, not directly related to affordability, but getting a lot of attention, is House Bill 1432, which is geared at expanding access to behavioral health services. So, and sort of strengthening the behavioral health parity structure. So I think other than that, Evan did a really good job reviewing the bill.
Great. Well, Ingrid.
Hi, it's Ingrid. It's hard to hear when you're virtual. Sorry, I'm not there today in person. Just really want to thank Evan so much for the really good work. We're feeling optimistic that we're getting at least a few key measures passed this session that would create that downward pressure on healthcare costs. And just suggestion as going forward, as we think about the connection between the board and legislators and activity they can take, is sharpening how our direction to them in the report prior to the next session of what this board is recommending that would require legislative action. And then in organizations, when supporting these different pieces of legislations that do align to the recommendations of this board is calling out the board. I've been trying to make a practice of that in some of our testimony and mentioning my role on this board, and that the legislation under consideration sort of flows from the recommendations of this board, just to continue to heighten their awareness of this entity. Thank you.
That's a great call out. Thank you, Ingrid. And thank you for reminding us that the sound is a challenge in here. I will endeavor to yell at the ceiling.
Yeah, it's in-person experience is better, I would say.
Thank you for noting the engagement of some of the board members. I know we've had a lot of board members, including yourself and Jane at OAC, as well as external partners at the Purchaser Business Group on Health, for example, that have been participating in supporting our agency request legislation related to the board recommendation on reference pricing. That was 5083, as Evan noted. That one is continuing to move through. So active engagement with a lot of stakeholders on some of these intertwining efforts. Are there comments or questions for board members on legislative activity? They will also be shifting into budget mode, as many of you are following that. The governor did release his budget priorities. The legislature is examining those. We anticipate seeing legislative budgets by the end of March, so we should have some update for you at the next board meeting in April. Thank you so much, Evan, for joining us today. Move on to tab 5. And we have a panel that will do a presentation today around that next dive on cost driver analysis and some of our all-payer claims database claims information. So we have Ross, who's going to tee up that panel.
Yes, thank you, Michelle. And I will try and speak as loudly as possible. Hopefully folks can hear. If not, please let us know and we'll try and adjust our decibels here. I'm really excited to introduce this work that's been going on with OnPoint for a while. So really excited to bring this to you. I'm just going to provide a brief introduction and then hand it really to the experts, Amy Kinner with OnPoint and Amanda Avalos with the hca with our department. Amanda is going to discuss the cost driver analysis and what provide some context and discuss what information we're hoping folks take from the presentation. And Amy will present on some of the data slides. And then I will come back at the end to see if there's any questions or any thoughts about additional work that could be helpful or revealing for the board about additional areas to look into regarding costs and mitigating increases in costs. So that's the general plan for this presentation. And I'm going to hand it over to Amanda for slides 2 through 7.
Thank you, and good afternoon. I'm Amanda Avalos, Deputy for Enterprise Analytics here with the Healthcare Authority. So let's move into the next slide. We'll talk about objectives for this conversation. We're going to talk a little bit about the difference between the data call and the performance against the benchmark that we've talked about the last few months and the cost driver analysis that we're going to be diving in today. We'll have some information around the drivers of cost, and this is based on the analysis from the all-payer claims database. Amy will be sharing that information with us. That will lead into some discussions and hopefully active questions around the analysis, which we're hoping will lead to some deeper and broader cost driver analysis needs. So discussion about where else we should go with a cost driver analysis in the future. Next slide, please. All right, so we are building on data work streams. So over the last few months, we've really focused on the item in blue, and that's the performance against the benchmark. That analysis helped us understand healthcare cost growth trends in the state. We were using comprehensive financial information that was collected specifically for the cost board. But now we're shifting over to green, that section in the green, the cost driver analysis. So today, using the all-payer claims database, there'll be discussion about key drivers of cost growth. Really, the intention here is for us to get closer to identify policies and strategies for the board to consider in order to reduce costs. So both the performance against the benchmark and the cost driver analysis are required in statute for the cost board. So you'll continue to see these on an annual basis. Some aspects of the reporting may evolve in future years, particularly the cost driver analysis, because we want to shape it to make sure that it's meeting the board's needs and that it's informing potential policy recommendations. Next slide, please. All right, so here you can see a comparison of the components for the performance against the benchmark and the cost driver analysis. So a way to kind of at a glance see some of the key differences in those analysis and the underlying data sources. So the cost driver analysis, which is our main focus today, that allows us to see more detail. Because it's claims data, there's also the potential to dive in further. We could go looking at procedures and regions, disease burden. So not all of these breakdowns will be included in today's discussion, but the data source behind it has that capability. So the key takeaway for this slide is that the performance against the benchmark and the cost driver analysis are separate, but they serve complementary purposes. Next slide, please. All right, so here you can see a little bit more of the technical detail and differences of the two analyses and their associated data sources. So again, the performance against the benchmark, the one we've been looking at, that's aggregated, it's very high level. It also concludes things that are non-claim spending, such as the net cost of private health insurance. So that does have financial information that we're not going to see coming out of the cost driver analysis. However, the cost driver analysis does give us that more detail, and we can do an examination of specific procedures and look at subpopulations. So there's lots of different ways to drill down. So you can look as you're comparing those two different columns, you can see that there's some shared capabilities between the two data sources, but they are very distinct and they do have different vantage points so that you're able to look at Washington healthcare costs a couple different ways. Next slide, please. All right, so the next two slides, what we're giving here is a glimpse of how the claim spending trends between these two data sources align. So you're able to see here data from 2017 to 2022. On the left is statewide, and on the right side, those charts are specific to the commercial market. You can see in blue is the all-payer claims database, and the data call data is in that kind of salmon peach color. So, most of you probably recognize that we don't expect to see identical figures between the two data sources. But what I think this illustrates is that we generally see alignment in the trends over time. You can see the commercial on the right side there, and then the trends all the way through. So the next slide, if we'll move on to the next one, it will give us the Medicare and the Medicaid market. So we're able to see the same detail, except this is specific to Medicare market and Medicaid. But the same message stands true, is that generally, for two different data sources, we're seeing a pretty close alignment in most cases. So this is trying to set us up to understand the fact that we've got two different analyses that gives us different perspectives, but we're really looking and seeing the similar trends for costs in Washington state. So at this point, let's see, we're moving into the analysis, the actual specific cost driver analysis that's going to be presented by Amy. Next slide, please. All right, so I'll hand it off to Amy, and she's going to share the specific analysis and the results from the 2025 cost driver analysis. Amy?
Have Amy sound.
Can you hear me?
Now we can, yes.
Yes.
Okay, thanks. So I'm Amy Kinner, Director of Health Analytics at OnPoint Health Data. We're located in Portland, Maine. And we've been working with the state as a partner, both on the APCD in general. We have been working with the APCD since 2016, but also with a cost board on APCD drivers of cost analysis. This is the second time we've done this analysis. And we did a lot of work with the team this fall to try to see how we can sync up the data to align as much as possible with the data from the data call. And what I'm going to show you today, there is a lot of data, but also there's a lot of other data that we have worked through and that we have the potential to do, but we're trying to focus today on a few key analyses. So next slide, please. So as Amanda mentioned, we use the Washington APCD to do the study, and it's important to note that the APCD one strength is that it has multiple payers: commercial, Medicaid, Medicare Advantage, Medicare fee-for-service. But as she mentioned, there are some data that are missing from the APCD. For example, we don't get the uninsured because they don't submit claims. We don't get military, TRICARE. Many of the uninsured plans don't submit, and there's other folks on plans from different states that may be getting care in Washington that we wouldn't see in the APCD. We also don't have most of the non-claims components of spending, including pharmacy rebate data. But we do get a lot of data, and we have the opportunity to look at diagnosis codes and procedures and patient demographics, and then also, to really investigate things around utilization and to look at drivers of cost. In today's presentation, we are going to be focusing on a few key service types, and that's inpatient facility, outpatient facility, and retail pharmacy. And those were chosen because they were the biggest components of spending out of the categories that we had. And we'll be looking by payer type as well. And then we're also going to do a couple of slides on behavioral health spending. So next slide, please. So the key metrics that we used in this analysis were looking at per member per month spending. So similar to what Amanda was showing, she was using a PMPY per member per year, but we use PMPM, but pretty much, the same thing, looking at how much an individual, or weighted by the population, how much spending was going on. We're going to look at utilization per 1,000 members. So this is basically services rendered, measured by claims, or for the inpatient side, it will be by the inpatient discharge. And then we'll also be looking at price per service. And when I talk about spending and price, we're talking about both what the plan paid and the member paid. So the total allowed amount divided by the number of services. And for all of these, we'll look, instead of looking at the actual values, we'll be looking at the percent change from 2017 baseline. So looking at sort of that growth over time in the measure. So next slide. All right, so we're going to start at a very high level. So we're going to look at all services that are in medical and pharmacy claims in the APCD across all payers. Next slide. And one caveat is that because we were looking from 2017 to 2023, we did not include, for most of these aggregates, Medicare fee-for-service, because we did not have yet Medicare fee-for-service for 2023. There's a lag in that data from CMS. So that's just one caveat, but we are going to break Medicare fee-for-service out separately, and you can see the trends there further on in this. But for the statewide spending, I want to orient you to this graph. On the bottom, you're seeing years from 2017 to 2023. And on the left axis, the y-axis, you'll see the percent change from baseline. So in 2017, that percent change is 0 because the baseline is 2017, and then it moves forward. So we look at it this way. We could also look at a year-over-year trend, but it tends to be more zigzaggy. So this is kind of an easier way to visualize it. But we do have the data to look at those year-over-year trends. And you can see here, 2020, it's sort of a dip. Of course, that's due to COVID. And the three lines, the darkest line, that's the PMPM. The light blue is price per service, and the green in this case is utilization per thousand. So you can see statewide, under overall these plans, spending increased by 30% over this time, these 6 years, driven by a 21% increase in average price per service and a 7% increase in utilization per thousand. So that's interesting, but of course, it begs a lot of questions. Were there shifting to different plans? Is there, what was really going on? So, and what services were really driving this? So we're going to start to dig in a little deeper to that. So let's go into the next slide. All right, so we're going to, I think I see a hand up. Yeah.
Hi, Amy. Sorry, I'm just curious, given the public comment that was made earlier about price versus service, where does intensity fit?
So I think that's a great comment. We don't have intensity in this study. But we can do that. We have ways of doing that. We're doing that in other states. So it's something we could add in the future, looking at that type of measure, and using sort of a reference pricing or percent or a Medicare fee schedule type of approach to look at whether there was shifting to more intense services. But we do not have that in this preliminary analysis. We're just looking at crude for price.
Sure, thank you. I mean, in some ways, it's probably hard to believe that intensity went so sharply, but anything that can give us some sense of how service intensity may be changing, even if it's from other data sources, would be helpful.
Yeah. And it, you could drill into different, you're starting at this high level, but you could drill into, with your inpatient, what sort of are the drivers of different categories of DRGs or things like that. There's a lot more you could do, but in this analysis, we're really just looking at sort of how did things trend, and that sort of creates more questions of places you might want to investigate further. So we'll move on to look at these 3 top key service categories. Next slide. So again, we're still looking at all payers with the exception of fee-for-service Medicare. And I want to orient you to this slide. And we have on the left, percent change PMPM, in the middle, percent change in utilization, and on the right, the average percent change in average price per service. We have orange is inpatient, green is outpatient, and blue is retail pharmacy. So if we start with the PMPM, you can see that retail pharmacy across all payers increased about 71% from 2017 to 2023, whereas outpatient increased a little more modestly at 48% and inpatient at 20%. And when we look at the other 2 graphs, we can see, the component of utilization and average price per service and how those may have contributed to this. And what kind of jumps out is the significant increases in average price per service for the pharmacy side and also for outpatient, and some increased utilization for the inpatient and the outpatient facility. So next slide. So just to summarize that, we did see across all these payers sort of increases in pharmacy PMPM driven by price, outpatient driven by both price and utilization. And that's going to be sort of a common theme as we go through this. And then inpatient, some growth, but not as significant, driven mostly by utilization. Now, one caveat I have here is that when we're looking at across all these payer types, we're not including fee-for-service Medicare, but we are including Medicare Advantage. And I think there was increased enrollment in Medicare Advantage over time. So we're probably getting more older people in these aggregate totals as we go through the years. So that may be driving some of that, increase in some utilization. So that's interesting, and that makes us want to, drill in a little deeper on the different payer types. So that's what we're going to do now. So going to the next slide. All right. So next slide, please. So looking at the same drivers of trend by each of these different payer types, we start with commercial, and you can see on the left the change in PMPM, retail pharmacy, again, not as drastic of an increase, but still significant increase over time. Also outpatient for the commercial population, significant growth in PMPM, whereas inpatient stayed fairly stable. When we look at utilization, we see pharmacy and inpatient actually, staying steady or decreasing a bit, whereas the outpatient actually increased 13%. And then when we look at average price per service, we can see that's really driving the changes, particularly in the pharmacy market. Next slide. And in Medicaid, we see kind of more, not quite as strong of a growth over time. So even in pharmacy, we are seeing 46%, but that is a lot lower than we'll see in the other markets. Inpatient, we saw some increase, mostly due to utilization. And then outpatient, we actually see some decrease in utilization and only a slight increase in PMPM. And as I think there's probably some impact to some of these figures from folks staying on Medicaid longer during the pandemic. Next slide. Okay, so now moving on to Medicare Advantage, we have, again, retail pharmacy, again, being the highest growth over time. Again, and if you look on the right, price per service for that retail pharmacy, very similar to the others, is increasing quite a bit. And you also see here in Medicare Advantage quite a bit of increase in outpatient due to more utilization on the outpatient side. Next slide. And then fee-for-service Medicare. So this is the first time we're getting to look at that data. Again, I'll note that it only goes to 2022. And we can see that the pharmacy, again, shoots way up to 97% growth since 2017, mostly due to price, but there is some increase in utilization for pharmacy for the Medicare fee-for-service population. And we see decreases in utilization for inpatient, and then also increases in PMPMs for outpatient, mostly due to increased price per service. And
Amy,
we
can I
have
ask
one.
a question?
Yep.
I just wanted to make sure I was understanding in pharmacy per service. Can you remind us if that's per script, per fill?
Yes, it's per fill. Another way that I think if we were to redo this analysis would be to look at the 30-day equivalents. That seems to be where other people are shifting, but yes, it's per fill.
Right. Okay. I was just wondering about dynamic, dynamic of fill of per fill.
Yeah.
Sometimes you get movement, happening in terms of what a fill, is, and
Yeah.
So okay, but thank you very much.
Yeah. Thanks.
Amy, sorry, related to that, remind me, what is price for in the retail pharmacy? Like what does that
Right.
mean?
So that is the total allowed amount. So that's what the patient paid. So it would be their copay, coinsurance, deductible, or whatever they paid for the prescription, plus what the insurance paid and submitted on the claim. So it doesn't include any other stuff that's going on with, rebates, because we don't have that data at this time.
Okay.
So it includes that, and then it divides by number of fills. Yep. Okay. Any other questions before I think we have just.
Sorry, then you're saying, Amy, that if it's divided by the number of fills, so when you say change in utilization for retail pharmacy, is that a change in prescription?
So the
fills? What is that?
Change in utilization for pharmacy would be like the change in number of fills. Yeah.
Thank you.
Okay. All right. Next one. And then we also have the exchange. You can see in the exchange, we had significant increases in outpatient PMPM, mostly due to actually combined due to increase in utilization and price. We also, again, saw the similar pattern in terms of pharmacy pricing driving PMPMs. And So that's sort of the review of all the different plans. Next slide, please. And then we put it all together on this slide where we put basically the whole percent change for each plan by each category. So on the left, you'd see retail pharmacy. The first one down is PMPM. So in that square, we see 52% from baseline for commercial, which is purple, and then all the other plans. And really to point out here, I think it's just reiterating everything that we showed on the other graphs, but basically retail pharmacy compared with outpatient and inpatient, retail pharmacy is consistently, significant growth across all these markets. Outpatient, most markets are growing, except for the Medicare Advantage, and inpatient, you see less growth. Next slide, please. So this slide just really goes over what we've already discussed. So that retail pharmacy growth across all markets, outpatient driven by both spending and utilization, and inpatient seems to be growing slower than other service types, and there's less utilization among commercial members over time. All right, so next slide. Now we're going to shift to the behavioral health spending analysis that we did. And next slide. All right, so in this case, we looked at behavioral health claim spending for medical behavioral health claim spending and compared to all medical claim spending. And we did not look at the pharmacy side of things. We didn't have a measure for behavioral health pharmacy. So these are just medical claims, and we can compare the behavioral health to the all medical. So the all medical is in the darker color and behavioral health is in the green. And what you can see is that behavioral health claim spending did increase at a higher rate than all medical claims. And this was really due to a change in the number of claims per thousand, and prices for behavioral health actually decreased over time. And the next slide, we'll talk about why that change in price per service may have decreased. But we did see definitely more utilization claims per thousand over this period. Now, one thing that we dug into a little bit was that even before the pandemic in 2018 and 2019, we did see additional claims volume coming into the APCD. We think there were some clinics that weren't submitting claims before that time, and there was a change, and they started submitting claims in 2018, 2019. And then after the pandemic, we think there was just more utilization of behavioral health services. Next slide, please. So this slide, we look at inpatient, again, orange, outpatient is green, and then we also have a category called other professional, which includes licensed practitioners that are not primary care or specialists. So this would include your counselors and social workers in behavioral health care provided in community health centers. And you can see that's really driving, that's really has a huge increase in PMPM. Mostly due to significantly more claims and utilization in that setting. So we're seeing a lot more professional use over time for behavioral health claims. And I think that's all that I have. So just to recap, next slide. So behavioral health spending is growing more quickly than total medical spending, but that's mostly due to more service use, and we're seeing most of that in the other professional service. So counseling, social workers, and community health centers. And next slide.
Amy,
yeah.
it's Shane. Can we go back a sec?
Yep.
So, and back another one. So I'm looking at okay, so we are showing, okay, I just wanted to make sure that you had broken that inpatient and outpatient.
Yeah.
Were.
One thing to note here, and I don't have these data, and as I'm looking at this,
We can barely hear you.
Okay. Can you hear me?
You were very clear before.
Yeah. Maybe somebody else. Can you hear me?
No.
Um, so I think one thing that I was just thinking about as I was talking is we're looking at percent changes, but that's not to say that the professional is the highest spending.
Right. That the per spending for inpatient stay is a lot more expensive than an outpatient visit. Okay, but I mean, this is interesting compared to the work that you did for us, which showed this seems like more of a higher change in price. I'm trying to remember the years of the analysis that you did for us for the dashboard. Was it 2017 to 2022?
I don't think it was that
That late?
I think it
It
was
might have been.
it was before we did the first cost driver analysis, which went to 2021.
Okay.
So Jane,
So
it might have even been before the pandemic. I'm not.
Okay. I'll pull up the dashboard, but I will say this to everybody else. In the work that On Point had done for us around behavioral health services, we saw rates for professional services as like pretty flat. So in a way, even though, oh my gosh, look at how much prices went up, this was probably after years of fees for these kinds of services being fairly flat. And when you think about the massive demand for services and the increase in claims that Amy referenced, it's almost like rates are kind of catching up with demand. I don't know, Amy, what are your thoughts on that?
Well, so I think you're talking about the professional side, and
Yeah.
that's the increase from 2017 is only at 12%. So that's 6 years. It's not.
Oh, it's okay. Oh, outpatient
So
is
it's pretty
outpatient
low.
facility. Oh, so it just back. All right. So
So
actually,
really, the
nothing
only
is better.
so what's really driving this is there's just more services
Okay.
happening.
Okay. So then basically this is consistent with what you found for us in your earlier analysis. Big increase in utilization, very little increase in price, which means for professional services, rates are staying pretty flat.
Yeah.
Okay. So it just confirmed. When I saw outpatient, I'm really sorry. That's my poor attention span.
And Amy, I'd like to also make another point. What we're seeing between 2017 and I think 2021 or so is integrated managed care, and so big changes that happen within Medicaid paid behavioral health, which meant that a lot of services started going through claims data systems, and so previously it hadn't been included within the claims data systems, but it started to in different parts of the state, gradually over time. So some of that increase in utilization is actually just an increase of claims being made available in the all-payer claims database. So we do want to highlight that point as well.
See a couple of hands up, Bianca.
Yeah, I'm curious. I didn't see much by way of this shifting that we've talked about in other conversations from inpatient to outpatient. I didn't see that kind of a consistent relationship. Actually, I saw very little evidence of that, at least in recent years. Can you comment on why maybe we're not seeing that shift here, or if I missed something compared to, I think, how many of our conversations have been going, is that there has been this big shift towards outpatient, but I'm not seeing it.
Well, I think we did see, kind of not a lot of growth in the inpatient side, and also in commercial, it was actually a decrease in utilization. And then we saw increases in outpatient. So I think we did see some evidence of that. I'm not sure exactly what the data what data you had seen, but
I mean, I'm just looking through the slides that you just presented right now, and the shift between inpatient to outpatient would suggest that you would see the decline in inpatient while an increase in outpatient. But generally, that trend didn't seem to pan out in any of the slides that you showed. But just in hearing public comment, and I think just conversation earlier, and I'm sorry, I can't point to an exact data source, but there has been this conversation about how we have been seeing an increase in outpatient services. And I just want to point out, I'm not seeing that in your data. So
Yeah, so if you could whoever's driving the presentation go back up a few slides to commercial, where it says commercial. Yeah, so I think, so if you look at the middle slide utilization, you could say there's a shifting. You have 13% increase in utilization on, outpatient, and a negative 13 on inpatient. So
okay, so you're saying, so even though I guess I'm looking at the trend line where generally outpatient, I guess, may be slowing down perhaps in the growth of outpatient services, and there's a slight increase in the growth in the outpatient services, but you're focusing on the point estimate of the negative 13 versus positive 13. That makes
yeah, so that's the total aggregate of across, all the years is that utilization for outpatient grew 13% and inpatient decreased 13%. But without actually looking into this more, we don't know if those are the same services that switched. We don't. It's not. We'd have to look into it more deeply. But I think it would beg the question of that, whether that was happening.
Greg, you have your hand up?
Yeah, hi, thanks. I just wanted to note, and I'm not sure how this will impact the data, that at least with commercial insurance, within the behavioral health space, there's just an enormous lack of providers that even take insurance. So while what they charge may have through insurance may have remained somewhat flattish, it's, they're charging enormously more to others, and that's not been flat-ish.
Yeah, Greg, your point is really well taken about the number of providers who just have cash only practices and choose not to contract with carriers for both fully insured and self-funded plans.
Yes, they're making plenty of money.
And if there's no further questions, I think we can pass it to, an additional question. Oh, please go ahead.
For context of the impact of each of these service areas to the total cost of claims, what's the percent, say, of behavioral health of total cost of claims? Or pharmacy to total cost of claims? Say pharmacy is 20%. Yeah, 20%, and behavioral health is 4%. That might be helpful for overall impact.
Yeah.
Yep. Stay.
Yeah, I think Amy's. Are you responding to that, Amy, or just observing?
Can you hear me?
We're having trouble hearing you, Amy.
Yeah. Can you hear me now?
Barely.
Yeah, sorry, Amy, we're not able to hear you currently.
Okay.
Oh, there you go.
Okay, gotcha.
Yeah, so I think sometimes something interferes with it, but yeah, I don't have those numbers like in front of me right now, but I can look through the data and put it in the chat in a few minutes after the presentation, if that's okay.
Great.
Thank you, Carol. And at the end, after Amanda, we're gonna see if cost board members have any additional questions. And it noted that regarding looking at total percentage of claims by kind of payer type would be interesting as well. So noting that, but going to send it back to Amanda for a couple slides to kind of orient us about what we saw, and then we'll finish up with any questions.
Sure. So these are some wrap-up takeaway for those of the conversation that we've had today for the cost driver analysis. One of the headlines is that retail pharmacy per member per month spending had the highest rate of growth, followed by hospital outpatient spending. And we saw this across all payer types. Also saw that hospital outpatient is marked by increases in price and utilization both. Hospital outpatient per member per month spending grew steadily over time. And this was driven by price and utilization increases in commercial, exchange, and Medicare Advantage markets. We also saw behavioral health claims per 1,000, particularly the other professional category, have risen substantially, but we also talked a little bit about some of the context that may be feeding into some of that. Next slide. All right, I think this is a handoff for Ross.
Thank you, Amanda. Thank you, Amy, for that excellent presentation. And really just wanted to take a moment just to pause and to see if cost board members had any additional questions or if any different ways of looking at this data would be helpful kind of to our overall project of looking at ways to reduce cost. And so just wanted to, I heard some great questions and suggestions about some additional ways of looking at this data that would be helpful, but I'm just wondering if folks had any interest in looking at those or not. And I guess I would ask Amanda and Amy to help me if we are getting some requests to just make sure it's understood by you folks who would probably be doing some of the data work. So just let me know if you need any more clarity. So now just open it up to cost board members. If there's anything else that you would like to take away from this data, or if you'd like us to do anything additional. I see Jane's hands. Please go ahead, Jane.
So Ross, the challenge that we always have, and Amy, we've had these discussions before, I think, the physician administered meds are embedded in inpatient and outpatient numbers.
Can you hear me?
Yes.
Yes. So they would be, yeah. And we've been, I think probably other folks have been thinking about that issue and how you can break them out. So they could be broken out, I think, in the future.
Okay, because it's just an area of great interest, I think, because the physician administered meds are the more expensive biologics, right? Chemo agents, and we hear a lot, especially on specialty meds, about how their prices are increasing and utilization too. So.
And Amy, is that something that would be feasible to do with the data set that we have?
I think so. Yeah.
Okay. And Jane, would you just reframe your question or restate it one more time, just to make sure we have it down accurately?
So I think the question is whether there is any way we can peel back a layer of the onion on inpatient and outpatient to get a sense of how much of price, if any, is being driven by increasing price for physician administered drugs. And I know it's a tough one to answer.
Excellent.
It's very possible to do. I mean, I don't know what the data limits are, but I do it for my population. And we should be able to look at both price and utilization.
So Greg, you're able to carve it out of like DRG kinds of payments? Okay, that's good to know.
I mean, off the top of my head, I can't tell you exactly how we do it. I just can tell you I know the answer. So we could, if needed, we could collaborate on how we do it. I'm just not sure exactly.
That's great.
Thank you for that, Greg. And I'd be happy to reach out to Greg and get some more detail on how his experience with doing this review. Are there any other members that had any additional kind of requests coming out of this on-point data that we just reviewed?
I guess kind of tagging on to what to Carol's question about the kind of the percent of the pie that is represented by each of the services that are broken out. I guess that a follow-on related question or hope would be about the contribution to the rate of increase. So we're seeing the increase, we're seeing the growth rate of inpatient, of outpatient, of retail pharmacy, et cetera. But that doesn't mean that's the contribution to the actual growth. And so I think that would be that's because that's what we want to understand what's driving, cost growth. And it seems that different types of services are contributing in different to a different degree. So perhaps I missed that. The answer is plain as day, and so that I apologize if that's the case. But I think it rolling this up, into a way to understand, for example, Carol, your comment about, so if retail pharmacy is like, oh my gosh, it's a runaway train, and then if it is, for example, 15% of total spend, and then all of a sudden it's 18% of total spend, and then it's 22% of total spend. I mean, it's representing a larger portion of the pie. I think that's especially important when we think about, the primary care spending that we want, right? Because we want primary care spending to represent a greater slice of the pie. So that it suggests that other slices have to be smaller as a percent. Pie is growing, but so anyway, I won't go on about it, but I think that's a part of the analysis, I believe.
That's an excellent question, Kim. And just to make sure I'm understanding it, so if we're looking at 2022 and total healthcare cost, THC went up from 3.2 to 3.7, you would want to know of that 0.5% increase, how much of that came from the inpatient sector, the outpatient sector? Is that what you're kind of talking about regarding?
Yeah. Yeah.
Okay. So
because it's investment, because it's overall we're investing in you're spending the whole pie of spending, but the pieces of the pie labeled various things are changing in size.
Thank you. Yeah, no, that's great. And I'll just turn to my data folk, please, Amanda, if there's
any. Thank you. So we do, and again, this is the cost driver analysis, but in the performance against the benchmark, we do have analysis that will show that breakdown that you're looking for. Some of that should be in the December meeting materials, but we can pull it out and highlight that and talk in more depth because that's a great point.
Thank you, Amanda. No, I can go back on that too, because as I was speaking, I was thinking that, I couldn't remember all of the data displays, that we've had provided. But it certainly doesn't strike me as something that we've just forgotten about. So anyway, thank you. No, I'll revisit the December packet too. Thank you.
And Greg, please go ahead.
Yeah, I think there's another really important question related to primary care. So for instance, spending more on primary care would be a good thing. We also look at, based on data, who we think has a primary care physician that they're engaging with. And the engaging part is the important part. But I can document very clearly in my population how much less each of those people spend every year on healthcare. So I don't know if in the data set, that could be done, but that to me would be an enormously helpful piece of data to understand is the delta between those who have an engaged primary care relationship and those that don't.
So Greg, would that look like a per member per month comparison between someone that utilizes primary care and someone that doesn't?
Correct. That's one way to look at it, yes. The delta in our population is rather significant.
And Greg, if you're still talking, we may have lost your audio.
Oh,
there you are. Okay.
okay.
Fantastic.
Sorry.
No problem. Thank you. Appreciate the comments and questions. And not seeing any additional hands. So we got, it looks like 5 to 6 really thoughtful questions for some additional research related to this. And so I believe that we'll be able to, I'm not seeing anything immediately stand out to me, and haven't seen anything from the data team that would indicate this isn't something that we'd be able to do. And so plan at the next meeting to give an update on when we can have this information back to you. And we'll also include in next month's meeting minutes a reflection of these questions, so you can help correct us if we misinterpreted anything. So I just want to really thank again Amy with OnPoint and Amanda and the data team for so much work on this project over a number of months. And I think the great questions we got shows how interesting this data is and how many opportunities we have in the future to continue refining and looking into it. So just really thank you, Amanda. Thank you, Amy. Thank you to the team for all your work on this.
Thanks for having us.
Yeah, thank you again for all of that work. I think we need to make up a little bit of time, so I'm going to shift quickly into tab 6 and our discussion with Joe Dillman on our grant-funded project called the Analytic
Support Initiative.
Yeah, ASI.
Thanks, Michelle. Thanks, Ross. Thanks, Cost Board. Nice to be here today. This is, I think I can catch up some time right now. I'm going to present on what we've been doing most recently on the Analytics Support Initiative. If we go to the next slide, this is just the reminder slide on what the Analytics Support Initiative is. We're about 1.5 years into a 2-year project, so not a ton of time left. But the real focus has been doing cost growth analyses for the Cost Board. And it's kind of been started under the kind of the hypothesis that you need to understand where the money's coming from and where the money's going in order to even think about controlling cost growth. So that's really the information that we've been providing throughout the project. Next slide. One of our, I think, big accomplishments was the report that we put together that I presented, I think last time I presented to the Cost Board. This is one of those slides that highlights the importance of service utilization, especially which is going down, and service price and intensity, which we show is going up in all the major types of care that we looked at. This is just a reminder that came together, was presented before, and we are currently working on an interactive visualization that will go live in the next month or two, and I'll present that I think at the next Cost Board meeting to this group, the interactive visualization. So next slide. So today's conversation is really about what we're going to do with the last 4 or 5 months of this project. And so my team and the HCA have worked real close over the last few weeks and months to kind of put together what do we have in bandwidth to take on, what analyses would be most useful. And we started with kind of a big list of opportunities and kind of whittled it down to what we thought was the most salient kind of analyses that we could still do. And so the questions that I wanted to highlight that we're going to kind of try to answer over the course of the next 2 months, 3 months, is about missing supply and looking really across payers and across counties within the state, and preventable admissions. So the idea is there's a set of health conditions that are determined to be preventable. CMS has a list, other organizations have lists, but we're going to take a look at where are those preventable admissions the highest, and where do we see outpatient care is the lowest? And is there a relationship, and to what degree does location and payer type connect with that? And then the second part of this analysis is trying to understand who's impacted and what is the associated spending burden associated with those preventable admissions. Next slide. So our way of doing that is kind of what I just said. It's quantifying outpatient visits per prevalent case or prescriptions per prevalent case. So we'll look at key diseases and look at the variation in those visits or filled prescriptions. And then at the same time, separately, we'll really look at the rates of preventable admissions or preventable ED visits, and then look at the relationship as well as where those are occurring and which payers are connected to essentially those preventable admissions and those gaps in outpatient care. Next slide.
Joe, I see that Jane has a hand up.
Oh, sorry, Jane, I can't see you. Go ahead.
No, I don't worry. I know it's hard. So thanks for this. Just quick question on the preventable illness or preventable conditions or whatever.
Yep.
Are there any behavioral health diagnoses in there?
So we haven't committed to a specific list yet. We've used CMS's list in the past, but well, we've used a couple of different lists in the past. I will get back to you on that. I'm not sure, but I think we could prioritize including some behavioral health and see what could be included.
Yeah, I mean, I'd love to hear from other folks as well, but usually, right, an ED visit for behavioral health is an indication of the fact that somebody wasn't getting the care they needed in the community.
Yeah.
So.
And we can break this out a few different ways. I mean, I think it mentions that we'll kind of look at the totality of preventable admissions, but we can look at individual health conditions and preventable admissions too. So we could pull out some behavioral health admissions as well. So,
Joe, could you say, my mind is a little bit confused between, I'm trying to understand the difference between preventable admission and preventable disease. And what's the track?
So I think the preventable admission is about all of the spending associated with the preventable disease. And so if a preventable admission is really about a health condition that could be managed outpatient and shouldn't lead to an inpatient admission. So an easy example is asthma. Asthma should be treated outpatient. It's not to say it's not a serious condition, it of course is, but it shouldn't be leading to ED visits and hospital admissions.
Right, at all. So I think, are we saying that any admission associated with asthma is preventable?
So different lists do this different ways. We could say that, and that's where I think we haven't ironed out exactly which list we'll use. We can also break it down by age and sex. So if, we could say for certain age groups, you would prevent an asthma admission would be preventable and others it wouldn't. So I think
see. Yeah. Okay.
There's still some, I think, of the logistics there to figure out. Any other questions? Okay, so what are we going to deliver? The goal is really to provide a short report in the form of a PowerPoint deck to the cost board. We're going to do that between now and June 3rd, and that would be the kind of the opportunity to present. Next slide. So there are lots of limitations, with our ability to make these sort of analyses. Want to be really clear about what those limitations are. One is that there's only 78 health conditions that we have our outpatient and inpatient admission estimates, and we have disease prevalence. And so that's certainly a consideration that we'll focus in on those 78 conditions. The limiting factor there is really for many health conditions, we don't have disease prevalence estimated at the county level. But that's really where we'll focus, is looking at everything relative to the prevalence within the location. And so that limits us to that 75 health conditions. We can look at others, but we just wouldn't be able to do in terms relative to the disease prevalence. As a reminder, our analysis goes through 2022, and our look at who is impacted is really about payers and counties. We don't have the ability to break out more granular demographics than that. And I think that's the last slide. If you could click one more. Yeah, that's it. So I will offer again any chance for questions, and then otherwise I think pass it back to Michelle.
Yeah, thank you, Joe. One question. You were talking about what list you'd be drawing from for some of those preventable admissions, and wondering the timeline on selecting that list in relationship to that kind of June deadline you had mentioned. How much time do we have to kind of identify what list we'd be using of those?
Yeah. So if the board would like to provide feedback on that, we could, for the next meeting, have maybe a preliminary. I don't know that there's a chance to present, but I will be, I guess, presenting on the interactive visualization. If prior to that, or maybe within the packet, we provided a list of what we're going to consider as preventable, we could then get some feedback if there is any at that point.
Yeah, thank you, Joe. And I would just put it to the cost board members. Would that be a helpful exercise to bring that back at the next meeting to kind of get to review some of those, what that list would be?
That would be great to bring that back so the board can see that, or at least send it, have it in the packet.
Excellent.
But I know at this point we had planned to tee up a vote, go back a slide that summarizes the proposal. We have planned to have the board just confirm this direction for the completion of the analysis project with UW. Complete the grant this year. So I'm looking for discussion and or motion to approve the strategy.
So this is Jane. I move to accept Joe's proposal, but would hope that we'd be able, and I know Ross, you mentioned about maybe bringing back the list for more input, but would love to see some behavioral health diagnoses in there as well. So what's my motion? Endorse this approach, and would request that there be an attempt to include some behavioral health conditions among the preventable admissions that are examined.
Can I just ask a quick question, sir? Is the goal to turn whatever is learned into policy recommendations? And I ask that because we know through other work, the news is all going to be bad. And we kind of know why. I mean, we may not have precision that we would get, but what do we expect to be different based on this added work? And should those resources be devoted to something else? Or maybe that's not an option. I don't know. Figured I would ask that question.
I'm happy to provide part of an answer on that and welcome others that have thought about this to chime in as well. But I think, Greg, you're right in some ways that we know the relative direction, and what we would be finding is a little bit more precision. So the precision that we can offer would be specific health conditions that are either particular variation across the state in how they're being treated, be it inpatient versus outpatient, and then particularly where are the locations and for those specific diseases that there is, unexpected variation, where there is less, less utilization of outpatient services and maybe more utilization of ED and hospital admissions.
And did you guys consider recommending any other approaches?
We did. We started with a fairly lengthy list, and the HCA kind of helped us whittle that list down to this being kind of the highest priority.
I think, Joe, also there was some discussion with the policy and data team here that supports the board around work not duplicating other work that is already on tap or is being produced by the APCD analysis or benchmark survey data. So trying to make sure that it was maximizing the grant focus on unique focus of work that Joe's team can bring to the table. And recognizing it needs to be contained. The grant does end by August, so this work needs to be completed by summer. And so it can't be a giant new research project that Joe's team can start in the next couple of months.
Thanks, Michelle.
Yeah, and thank you, Greg. I really love that question. And to Michelle's point, we did try, when looking at the larger group of questions, to identify those that we thought would duplicate prior work or work currently in progress. And these were the ones that we thought offered the most new information, particularly related to kind of the geographic element that we get in question one. But certainly welcome any feedback or additional direction related to this, today. And also to Michelle's point about the contract funding kind of wrapping up at that time and needing to pick a project that was right sized for the amount of time that we had. So that's kind of some of the background information of how we got here. So I should have included that at the beginning. So my apologies.
I mean, it sounds like others have really looked at the recommendations. I just don't think we're going to really learn anything new, but I'm probably the only one with that opinion.
Well, when possible, I have a question about what we might see that's new, or we might understand a little bit better. So I think, Joe, you remember that several meetings ago, we had a very brief conversation about what we might be able to learn in this cycle, or maybe in the future still, about investments and resulting health or reduction in disease burden. So we talked about, we're concerned about spending growth, which can be considered investments in health, sort of. We're also concerned about disease burden, preventable spending, all of that. So is there a relationship, like in this analysis, will there be something to see about the spending, where it's happening, slices, dices of the spending, and what we're getting for it? What the distribution of disease burden or health, perhaps health status indicators. I haven't heard any conversation about health status indicators, but from a public health standpoint, is there something to see or start to see from this analysis about what we're getting, where we're getting something that seems a little positive versus where we're spending more and getting less?
So the goal would certainly be to look at the relationship of, both outpatient versus admissions. I think what we would walk away with would not be a number in terms of like a return on investment. That would be a great output that is probably not within the scope of this project. But I think what we would be finding is both relationships about how we're seeing within the state, across counties and across time, how we're seeing changes in outpatient visits connected to inpatient admissions. So that
and
sort of
costs,
and costs, absolutely.
Yeah. And spending associated
Absolutely, yeah.
with the very right.
Yep, exactly.
Carol has a question as well.
Sure. This might be along the lines of beyond the scope, but when we look at missing supply to address healthcare issues, telehealth, virtual care has risen to meet the need. That's not a component of this study. from what I'm seeing on the key questions that are asked. But it has been an answer that came about because of COVID. People out of necessity had to turn to virtual care, and it frankly has been a saving grace for those that have mobility issues. It's been a healthcare equity connector, and in some respects might illustrate a solution, particularly for a portion of the states that has a dearth of providers. And
Yeah.
so I don't know if we can expand scope at this point, but I think it might reveal some interesting geographical solutions in our state and give us some new answers, getting to Greg's point of what can we learn new here?
Thanks, Carol. So at this point, we wouldn't be able to stratify by tele versus a regular outpatient visit. Those would be combined into a single category, which I think is good. The point is we're including telehealth, and so it's not that it's being ignored, but it's not being, we wouldn't be able to look at a county and see the ratio for a disease of an outpatient visit versus an outpatient telehealth visit. So that is probably a little bit out of scope. It is work that our team is doing, and is something that we could think about connecting the cost board and our team at a later date, but by the June deadline, certainly wouldn't have it by then.
Understood.
Thank you all for the comments. I know we had a motion on the table and it feels like perhaps we need to have more discussion at the next meeting back with Joe's additional information and follow up on this discussion. That, I think we can, thank you so much, Joe, for that.
Thank you.
We're ready to close out this presentation and the final topic that we can squeeze in the next 15 minutes, okay? Quick sprint. Tab 7, we have a staff discussion overview of the NASH model, the data, gaps, or opportunities. So turning to Ross, Ali, Jen.
Yes, thank you, Michelle. Very excited to bring this topic back to the cost board. Just a quick refresher. The NASH model, the National Association of State, oh no, I should have wrote this out. State Health Policy. A national organization had put forward a model piece of legislation about increasing transaction oversight over healthcare facility types. And the board had previously, I think going back to the November meeting, asked for some analysis of the underlying data gaps potentially that would be presented by this bill. And then in some additional questions related to that. And I believe it came up several more times at the January meeting, December meeting, just more questions and wanting to lean into the concept of increasing transaction transparency and oversight as seeing that as a driver of costs for healthcare. And so HCA staff has kind of taken a look at, and Audrey, would you go forward for me? And I apologize, doing just a little audible here with our short time. Back one slide. Perfect. Is this the first of the table? Okay, perfect. So what we did was we wanted to orient you to kind of the current lay of the land in terms of what facility types were called out in the NASHB bill as being subject to this increased transaction oversight when there's mergers, acquisitions, affiliations. And you can see in your packet, we listed out the facility types that would be included. And you can see in the columns on the farther right who the state administrative agency who has oversight of those facility types currently are. And if you would just push ahead, yes, one more slide. And so again, just hoping that kind of on with these tables that you're looking at, the intent was to show what facility types NASHB calls out to be regulated, who's currently regulating them. And then we wanted to also bring in some Washington state legislation. Some bills have died, some are still alive, but as examples of the NASHB model kind of put into Washington state bill proposals, which will always look a little different than the model, and tried to also show what facility types were called out in those Washington state bills for increased transparency regulation. And again, calling out what agencies currently regulate those. And then you'll notice on the last page of this table, what I was really kind of hoping to draw down to was that these transaction oversight bills call out facility types, just using a couple examples: urgent cares, freestanding EDs, to some degree dialysis facilities, that we don't currently regulate at the state level, or no state agency has oversight over that facility type. But it is a type of facility that these transaction bills call out as being included. So if there is a transaction, a merger, affiliation, this facility, a freestanding ED, would need to notify under the model, the AAG's office and the healthcare authority, to notify them of a potential material change transaction. Kind of where my alarm bells went off a little bit in kind of looking at this, kind of coming from working at OIC and DOH, and this has been a common theme kind of in my enforcement regulatory career, is we the state lack data on a number of facility types, particularly those we don't regulate, and seeing the interest by the legislature by these number of bills that we refer to in this table that are acting on parts of NASHB. Recognizing that it would be very helpful before launching into this increased transparency work to have some way of knowing who those facility types are, particularly those facility types that are not currently regulated, but that we're seeing indications from the legislature that they'd like to have that increased transparency and oversight over. And so as a model or an example of a way to increase our knowledge of those facility types, we just included a few notes related to the provider registry bill. Simply as an example, we're not offering any position on that bill by any means, but just as an example of the type of structure, the provider registry, which would require healthcare facilities in Washington state to affirmatively report their contact information, demographic information, and possibly some ownership affiliation information, which would give us the ability to then know what healthcare facilities are in Washington, which is simply knowledge that we lack now. We do not have oversight over all facility types. And so I apologize kind of for the rambling presentation here, but really wanted to try and convey the message or convey the point, at least as I understand it, that these are really exciting bills in terms of increasing transaction transparency, also transparency over costs for healthcare facilities, but thinking that an important first step or foundational step would be to have something like a registry or some affirmative requirement for facilities, healthcare facilities, that we think should be subject to this increased transaction transparency or cost transparency, that they be subject initially to something more like a registry or some affirmative requirement to notify us, so that we would have the information and ability to then, if a transaction bill passes, to be able to know who they are, how to contact them. If they have not complied with a transaction bill and have not notified the appropriate offices, that we have some way of determining that they did not comply and then take appropriate action. And also understanding kind of the lay of the land with our healthcare facilities, those that we don't currently regulate. Getting some information on them would allow us, from a geographical perspective, I think, to add a really interesting perspective to kind of our cost board's work of looking at increased costs, but being able to put a more geographical spin on it if we're able to map out where each facility type is, and kind of acknowledging the differences in healthcare delivery in our state between, the east side, west side, rural, urban communities, how our costs function compared to some of our larger health systems in our larger counties. So seeing a really interesting opportunity for that type of registry model to, one, be in a foundational step for us to lean into the NASHB type models, increase transparency oversight, as well as adding a new helpful dimension to our cost board work in terms of better understanding geographically where how our healthcare delivery is structured and set up, and adding that extra layer to our analysis. And so I wanted to just provide that update in response, as this NASHB topic had come up at several meetings before, and I apologize that I kind of rushed through this presentation, but wanted to kind of open it up for questions and see if there was any further work that the board wanted to consider related to the NASHB bill, or identifying data gaps, particularly related to facility types here in Washington, that would be helpful to the board's work. Or is this something that would be more helpful to revisit kind of in the year-end report to kind of see where, legislative session took us, what bills passed, what bills didn't, and then consider if we would want to recommend some type of structure to bring new facility types under, or at least provide the state with contact information for those new facility types. So I think there's a couple different options here. If there's interest in pursuing more information or holding off till the end of the year, including a legislative report, really it's up to the board. So just wanted to open it up for any questions or feedback related to this presentation.
And being at the moment, so I know we can circle back on this conversation certainly as we see what bills are live in our next meeting and how that work relates to the ongoing policy work that we really will hope to push up the steam on it, probably the June meeting.
Yes.
And I don't think you can see the chats, but I have been reminded by staff that manage the ASI grant that we do need to have the vote, because it is a condition of the funding release. So we need to go ahead and circle back to our ASI funding discussion with we've completed conversations on this.
Excellent. Well, I will wrap up this NASHB conversation. Again, preliminarily, we are internally talking about maybe ways that this could be referred back to in the year-end legislative report, and we'll continue to talk about that with the cost board as we get closer to that. But just thank you for your time. Sorry for talking at you for so long. And just really thankful for everyone's participation today, and we'll send it back to Michelle for the ASI vote. Thank you, Michelle.
Thank you. Great overview. Thank you all for putting together the package of information that's in your board packet, so you can look at that. We can circle back with more conversations if you have them for next meeting. We could turn to Joe's proposal with the strategy to do an analysis on some preventable admissions. Yeah, that's perfect. I heard a motion from Jane. So Jane, would you like to reiterate your motion supported moving forward with the addition of some behavioral health data?
Yeah, I think the motion was to approve the key questions and analytic strategy that Joe proposed, but to attempt where possible to bring some behavioral health conditions into the mix of preventable admission.
I'll second that.
Carol? Yep. All right. All in favor, say aye.
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 Opposed? Nay. So carried. Thank you for noting, Harrison, that we needed to take care of that today.
Yep, and Michelle, just one thing, and to Greg's, to sort of honor Greg's question, we've had, and I think Amanda did a really good job today, sort of like comparing what the cost driver analysis showed us versus what the HCA, the expenditure reporting, and then we've got Joe's work. I think it might be helpful, if possible, if we could sort of look across that research that's been done and think sort of globally about how that research informs sort of where we go next or where we want to go next. Sort of saying, despite methodological differences between the three different analyses that have been done, where are the consistent themes that would give us the information that might be helpful to move forward on policy recommendations for the report this year. In other words, just I would really benefit from like a connect the dots discussion. I have a simple brain. I think that would be beneficial to try to pull together all the work that's been done.
Thank you.
I agree with Jane.
Excellent. Appreciate all of you calling that out, and I'll note that the staff does have a plan to do some advanced planning work and bring that back to the board. That is in process. And let me just apologize and acknowledge up front, we have a brand new staff team. And so I think that they're doing amazing work, and that means we're a little bit late on some of that advanced planning and spelling out the significant policy agenda for the rest of the year, but that will be done. And our plan is to bring that to the next board meeting. So thank you all for noting that we need to shift our gears. We are in process to do that, but again, noting the staff have just joined us in December and January. They're really pushing us fast and bringing us along, filling in the gaps. So thank you all for that work. I think we're ready to wrap up, but I want to note that our next board meeting is scheduled for April 24th, 2 to 4 p.m. We'll again follow up with legislative updates, this conversation, and hopefully some policy groundwork and planning work. In the meantime, there are the 2 committees meeting on March 27th. That is also from 2 to 4. The Stakeholder Advisory Committee and the Data Advisory Committee are both meeting. And hopefully we'll have some feedback for the board meeting as well. So with that, I think we're ready to adjourn unless there's some closing comments or any questions. Thank you all so much for being here today. We really appreciate your time and your engagement and your guidance on these important conversations. So have a lovely day. See you again in about a month. Thank you.
Bye all. Thank you.